Good morning, everyone. My wife likes to call me an 18-year-old stuck in a middle-aged body. I've got an iPad and an iWatch and all of that technology, so I'm going to use some of my technology to spend the next 22 minutes talking about what we're doing at Cambia. So I serve as Executive Vice President and Chief Medical Officer for Cambia Health Solutions. Just a show of hands, how many people in the room know Cambia Health Solutions? Okay, a fair number of you. We're a health solutions company, and that company has three divisions or verticals. One is the standard health plan vertical, which has 7 health plans in 4 states. Another division or vertical is our invested portfolio vertical, and we are in partnership with the Blues plan out of North Carolina in a joint venture where we have merged our investment companies into Echo Health Ventures. But I think the most important vertical or division in our company is our human experience platform. It's a very different term that you would hear from a health plan or a payer, because in essence we're not a payer. A payer is just part of our portfolio, and we are intensely focused on trying to understand the human experience, the consumer journey, and then make that marriage between evidence-based care and that journey to get a better outcome. And that's what I want to cover today. So I'm going to briefly in this 22 minutes go over that, and hopefully I'm able to communicate the spirit and intensity that a cause-driven company like ours has each day trying to help the people that we serve. So some of this is about data, and if you think about data, particularly from a health plan perspective, it's basically claims data that we collect, which is always old by the time we get to use it, and it's always looking in the rearview mirror, looking backwards about what happened, hoping that that might be helpful in predicting what will happen. And it's not very predictive, as some of you may know, in the predictive models that have been around for years. They don't find the right people, typically, and the results are not, from a financial and an outcome, a non-financial outcome perspective, not very helpful. So we're transforming ourselves from a data perspective. And you can go to the next slide if we have slides. What we're trying to do is transform how we think about data. We've hired 15 really smart, brainiac data scientists who are thinking with new models of data analytics about the data that we have. So today we're trying to think differently about the data that we've had for years, and tomorrow we're going to think about data as a service so that it becomes intensely predictive. That's the journey, but that journey is in the context of a dysfunctional healthcare system. I had hoped back in 2010, as we were beginning to start on the next wave of healthcare transformation, ultimately leading to ACA and ultimately leading to where we are today, which I think you would all describe as we haven't made a lot of progress, even though there's been a tremendous amount of effort by a lot of really great individuals. We still have a dysfunctional healthcare system. We still have a healthcare system that is fragmented, and there's very little knowledge and insight about what the consumer experiences when they leave the physician's office or the hospital or other healthcare professionals' offices. People don't understand from a healthcare professional perspective the challenges that somebody has, financial challenges, family challenges, and so on. So we have a very dysfunctional healthcare system today, despite all the work. And so what I want you to do is I want you to imagine the possibilities. Imagine a healthcare system that understands the healthcare consumer in its entirety, a 360-degree view of the healthcare consumer. And that view goes beyond the walls of a physician or healthcare provider's office, so that you understand all of those impacts in the healthcare journey, and you can marry the evidence-based treatment of that journey so that you get a better outcome. And much of this involves people outside the office in their homes, which is so relevant to what you all do. So we're trying to accomplish a seamless, personalized healthcare experience for everyone who we serve and provide care where people are and how they choose to receive care, not care that is provider-centric or unrelated to the consumer experiences that they go through. So let me tell you a story, just to kind of put a fine point on this. We were involved with the care of, or facilitating the care of a 6-year-old girl with a terminal illness. She lived in a rural environment, and so it was a long trek to get to her doctor's office. And the doctor visit was very technical. It was, how are you doing on the treatment plan? Are you having any side effects? Are you having pain? Is it in control? And it was very technical and what you would expect in a typical office visit. You sit in the waiting room, you get into the exam room, you put on the blue gown, you get examined by the physician. They're very professional and courteous, as you would expect, and then you leave. And in this case, they had to travel a far distance back to their house. Well, as this individual, as this 6-year-old got increasingly sick, it became more difficult to travel. So out of that acknowledgement, the provider established a telehealth capability for that individual. And when they started to engage from a telehealth perspective, they now saw this child not in a blue gown in an examining room, but in a home surrounded by stuffed animals in her bed. And in that safe environment, in that home environment, she was able to articulate fears and concerns that she wasn't able to communicate in an examining room. And one of the biggest fears she had was that she couldn't sleep. And she couldn't sleep because she was afraid that she was going to die, and if she died in her sleep, she wouldn't go to heaven. And there was a simple, heart-tugging solution to this, which is some of the staff in the provider's offices went out and got her wings and sent her angel wings to her house. And so now, by understanding the home environment and understanding the experience she has, not from a clinical perspective, but from a whole person perspective, they are able to solve a problem for this little girl. She slept with those wings, and she started to sleep more because now she had that vehicle to go to heaven. So this heart-tugging story, but it's a story that embraces this concept of understanding the individual beyond the medical model, the clinical model that we're also used to. So we need to work together to provide care today, knowing that, and tomorrow, that approaches individuals differently than we currently do. And we have to look outside of our industry, and we're in California, so what better company to look at than Apple? And Steve Jobs was very focused on this issue. He didn't attack the technology solutions that are now available in the market like this. He didn't attack them from the perspective of what technology can we build. He attacked them from a liberal arts or humanities perspective, understanding what consumers really wanted, and then layered technology on top of that. This liberal arts, if you think about it historically, was another name for humanities, which is kind of what we're talking about. And ancient philosophers used to describe that as the just, the beautiful, and the good. And so if you think about that, if you think about the humanistic concerns that Apple had, and then layered technology on top, it's no wonder that there's been such uptake of technology like this or like this. And so that's what we're trying to do at Cambia. Cambia is cause. We don't have a mission, we have a cause. So we're a cause-driven company and a total health solutions company, as I said. And in our view of the consumer, we're trying to make sure we understand where and when and how consumers want their care. And we're looking at everything from birth to death and anything in between, from health, so you don't have to be sick to be part of what we're trying to solve for. And we're not only treating the body, we're trying to help facilitate the treatment of the mind and the spirit. And that's what we do every day. That's the basis for our human experience platform. And we're really trying to deal with two sides of the same coin: the medicine side, the scientific side, and the humanities side. And if you bring those two together and create an intersection between humanity and evidence-based care, you're going to have a better experience for the people that you serve, and you're going to have better outcomes because you'll be much more knowledgeable about the journey that they go through. So bringing humanity into healthcare for us is front and center, critical, important. And some of the ways we do this is we rely on data and technology. So let's see, if we can put up a slide. Well, maybe, this is a very complex slide, and it comes at the end of a presentation that I do on how we use data today to inform clinical decisions. So let me orient you to this slide. I'm not going to go into detail, but it will give you a window into how we think about things. In the past, we would take claims data, which is the top left cylinder, and that's what we would use to create predictive models. It wasn't very predictive. The PPV, the positive predictive value, wasn't that effective for us. So we scurried out with a lot of staff, nurses, and other staff, and engaged people, and it was really engaging people who weren't really either willing to be engaged with or weren't the right people. And so now we are adding to that clinical data through EMRs, and we're partnering with providers, consumer data, so we have insights about the consumers that we serve, and then wearable and social data that comes from your iWatch. And we're even taking data, so I'll talk in a moment about falls, caregiver data, so that we understand critical markers that might impact these models. And we're looking at these models to define a population, and then we're putting a fine point on that population through risk scores that are far more predictive today than they have been because of our smart data scientists, and engagement scores. So we don't want to focus on people who have an opportunity to get to have something modified that will help them if they're not willing to get engaged. So with both of those, we can narrow down the population, and you can see the red individuals are high risk. You can see that the percent of high-risk individuals in the targeted population is much greater than would have been in the past. Now, most companies stop there. They create an engagement, an outreach, they engage with these folks, and then the CFOs come in and try to calculate the return on investment. How effective was this? Well, I'm not saying that that's not important, because that is. I know it's important to many of you. But this model is a learning model. That's what's so really cool about these new data models. So every interaction that our nurses and other staff have with individuals on this list, that information gets fed back into the model. And that model constantly learns. Every day that model is taking new information in and learning, so it's getting better and smarter every day. And let me give you two examples of how we do this. This should be very relevant to many of you. We have a falls model. There's been a lot of falls model in the past, but not with this fancy analytics. So you probably know the statistic better than I, and so these are directional numbers. There's about 18,000 deaths related to falls each year in the home, about 700,000 hospital admissions related to falls at the home, and 7.2 million visits to the emergency department related to falls at the home. It's a pretty big problem, right? And so we're taking the model that I described here and applying it to falls so that we can better predict who is likely to fall and create an intervention to try to reduce that probability. And we're doing that not just in the way that we've done it in the past with care managers, care advocates, nurses, et cetera, reaching out, but we're doing that in collaboration with a bigger frame of reference, including caregivers at home. In fact, as I said before, This is dangerous over here. As I said before, we include caregivers in our model as a predictive component of our model. In fact, we have 2,000 variables that are inputting into this model today. That's why I said these guys are so smart. And if you take our total population, we have roughly 2 million members in our health plans. If you take 2,000 and multiply that by 2 million, you can do the math. We're doing a lot of data runs each day just for this one model. And we have over 30 models that we're running every day and surfacing information about individuals every day. So we're excited about this. We are early in our journey on this, so we don't have results, but we think this model and its profound implications will have a material impact over time. Let me pivot to another area, and this area is one of the highest priorities for our company, palliative care. So we're working with a company called GNS Healthcare. Has anybody heard of GNS Healthcare? They're a Cambridge-based company. We happen to have an investment in them, and they're also a smart data company. And they have created a smart algorithm that is able to identify individuals with serious illness who are likely to die in the next 12 months. And their algorithm is 50% better than any algorithm out there because of these smart analytics. And it enables us to target our resources to the people where we can make the most difference. And so we are doing that. And the positive predictive value of these models based on the population that we're addressing is exceeding 50%, which is much better than models that are out there. And so with that, we engage. We have 6 case managers in palliative care. And by the way, we don't define palliative care as somebody older with a serious illness likely to die. We have expanded our view of palliative care to include anyone. From pediatric palliative care, we just launched one of the first neonatal palliative care services in the country. And what a heartbreaking moment it is, and a moment that hasn't been addressed for somebody to go through 9 months of pregnancy only to deliver a child who's got a terminal illness. And so we launched a program in the late part of 2016 to address that. So all of this is informed by data, and we are feeding the results of the interventions that we have by our case managers back into the model, and that model is learning. And I would point out that our interventions aren't get somebody to hospice or save money. Our interventions are acknowledging the consumer, the experiences that they have, the situation that they're in, and give them the range of options and let them choose, because it's their choice, it's not our choice. I can't tell you the number of times as a resident in training where there was a do not resuscitate sign on the door of a patient and there was a full code going on because residents didn't want patients to die on their shift. And that's, it's understandable but not acceptable because it's not reflective of the wishes of the individual. Last year we announced partnering with CAPC, the Center for the Advancement of Palliative Care, on a home-based palliative care program. And if you could show this next slide. This is an individual who has ALS. And the woman is a clinician who's with her and is one of our Sojourn Scholars. 3 years ago, we started a Sojourn Scholar Program where each year we train 10 clinicians for 2 years in palliative and end-of-life care. So we're trying to create the next generation of palliative care, national palliative care experts. And he or she is with an ALS patient. And you don't see grief and despair, you see laughter and life. And so this is a situation where somebody is defining how they want to end their life on their own terms, in their own settings. And this is something so important to us and so important to the soldier and scholars who are working with us. And I'm sure you'll agree. So, in conclusion, God, I'm right on time, so I feel so good. In conclusion, this is about healthcare providers attending all the needs of patients and their families. This is about not just physical and evidence-based care, but about spirituality and understanding and acknowledgement of healthcare consumers throughout their healthcare journey. Whether they're in a physician office or provider office, or they're at home, or they're at work, or they're at their kids' parent-teacher conferences, this is about understanding the totality of the human experience. It's informed by intelligent and actionable data, and it's in this combination with humanity, it gets back to the just, the beautiful, and the good. So please, I hope I've shared enough information in this short period of time for you to imagine the possibilities. And with that, thank you for letting me speak to you.